Okay, good morning, good afternoon, and good evening to each and every one of you, depending on your time zone. It is great to see you all connected. So we will start this session now. My name is Tolib Mirzoev. I am Professor of International Health Policy and Systems at the University of Leeds, and I'm also elected member of the Health Systems Global's board. So I have a privilege of chairing this session. What I would like to do now is to very briefly introduce the controls. I think those of you who have been attending the sessions during the first phase already probably know, but just in case, on your right-hand side, you have got a number of functions, session information, session preview, live Q&A, and discussion room, and handouts. So throughout the presentations, and we will start the presentations in a moment, please put your questions in the live Q&A question and answer section. But if there are any issues that you would like to raise just for others, then please put in the discussion room. I will be able to keep track of questions in the live Q&A. So please make sure that you put in whatever you would like to address to the panelists, to the presenters in the live Q&A. Okay? And where possible, please also indicate who you are addressing your questions to. Okay, so today's session is focusing on understanding the practice of power across sectors relevant to health. So we all know that power is fundamental to health policy making, health system strengthening, and there is an increasing and growing body of literature, both empirical as well as theoretical, that touches on power from many different angles. And we have got 5 exciting presenters with really interesting topics lined up in this session. So our first presenter is Miss Ida Okeo. So Ida is currently a public health PhD student at the School of Public Health, the University of Western Cape in South Africa. Her PhD work is focused on studying the policy processes of intersectoral initiatives, particularly during policy formulation and implementation. As part of her interest in policy analysis, she was part of the Alliance for Health Policy and Systems Research Fellowship Program in 2017. So Ida will present her work entitled on policy adoption and implementation challenges of the intersectoral first 1,000 days of childhood policy in South Africa. So in a moment, the presentation will go as planned in a pre-recorded format. So what I would like to outline is after each presentation, I will pause very briefly for any questions for clarification. Again, put any questions in the live Q&A. I will try to differentiate clarification questions from more comments, and I will defer comments until all presenters have spoken. And then we'll open up the Q&A for reflections and feedback from the presenters. So, but please do put in your questions in the live Q&A, and also use the discussion forum to introduce yourselves. Feel free to say who you are, where you're from, and what are your interests. Okay, I will stop now, and our organizers will play the first recording.
My name is Ida Okeo. I'm a PhD student at the School of Public Health, and today I will be talking about the policy adoption and implementation challenges of the intersectoral past 1,000 days of childhood policy in South Africa. So there's a growing interest in intersectoral action for health, especially in the Sustainable Development Goals era. However, there's been limited evidence that has explored how and why efforts towards intersectoral collaboration succeed or not, especially how to implement intersectoral approaches in low and middle income contexts. And so the focus of this presentation will be to explore and understand how health systems can begin to address social determinants beyond predominant biomedical approaches. This particular presentation will use the First 1,000 Days initiative as a lens of looking at how intersectoral initiatives unfold during policy processes, especially decision-making processes of formulation and implementation. The First 1,000 Days initiative is based on the premise that the first 2 years of a child's life are vital for brain development and growth. And so the provincial context, the Western Cape province aimed to address and try and improve child outcomes by focusing on nutrition, health, education, support and parenting, as well as protection and safety. That was the initial goal in 2016. However, similar to many other policy initiatives, although there was an initial intersectoral approach that was advocated, in 2017 and 2018, there was evidence that the intersectoral goal had thinned into a narrow health-based focus. And so this presentation is really to explore why First 1,000 Days transitions from an initial intersectoral goal to a biomedical focus. And to do that, I will draw on key informant interviews, observations of policy processes, as well as document reviews. And the analysis of this particular research was informed largely by policy analysis theories, such as the Ideas, Interests, and Institutions framework, which really tries to investigate how those three factors interact and influence policy processes. And so I will present my results based on that particular understanding. So really the policy thinning of the First 1,000 Days was informed by the lack of clarity and varied policy ideas that surrounded the First 1,000 Days. The quote at the bottom of this slide really shows that a lot of the actors that were involved in the First 1,000 Days knew about the First 1,000 Days, but there was a lot of ambiguity surrounding what the First 1,000 Days was. And so actors had really different ideas regarding interventions for the First 1,000 Days. There was a particular contention regarding whether the First 1,000 Days should focus on maternal and child health or have a broader intersectoral focus. And when we looked at policy documents that were available, solutions for the First 1,000 Days were either proposed to be biomedically focused or nurturing care focused or had a broader socioeconomic focus. The second reason that contributed to the thinning of the First 1,000 Days was that there was underlying tensions at sub-district level for implementation actors, particularly because they felt that they had to navigate multiple demands that were coming from top provincial structures, as well as the pressure that was emerging from advocacy groups and technical support groups. And so actors at service delivery did not have ownership for the First 1,000 Days. This was worsened by the loss of key champions who were involved in earlier agenda setting processes, and of course the fact that the First 1,000 Days really did not have cross-sector actors. And as a result, there was resulting frustration for both policy advocates and for those who are involved in implementation processes. The last reason was really that the First 1,000 Days was shaped by a range of institutional constraints. There was a historical pattern within prioritization in the provincial context of initiating vertical projects or initiatives. And so health sector actors viewed that the intersectoral mandate was too ambitious and too overwhelming for the health sector. Of course, the health sector itself had a range of constraints, such as complex service delivery contexts that were shaped by high patient numbers, ineffective referral systems, and many others. And health workers really had limited capacity and did not know how to engage intersectorally. And lastly, other priorities that the health sector was involved in, such as the Management Efficiency Alignment Project or the Community-Oriented Primary Healthcare Approach, were taking place at the same time as the first 1,000 days. And so what that meant was that management lines were at times disrupted, and attention at certain times was taken from the first 1,000 days. And was involved in trying to initiate the primary healthcare approach. And so based on these three factors, we see that initiating intersectoral collaboration and ensuring that it's sustained can be shaped by the following factors. The first is that we need to acknowledge that agenda setting for intersectoral initiatives without adequate bureaucratic commitment can really hinder action and can affect how actors sustain commitment to engage intersectorally. And then, of course, engaging cross-sector actors becomes very vital, especially during agenda setting, and maintaining those relationships throughout the implementation process is crucial, particularly for actors who are responsible for service delivery, as they need to own the process and will be involved in delivering the goals that are set. The third and main reason is really that intersectoral processes are shaped by actors who have different ideas on interventions, largely because they come from different sectors. And so we need to acknowledge how to navigate different views of policy solutions. And one way can be through supportive bureaucratic cross-sector networks, which really ensure that actors have a relationship and can engage and develop common views or common ideas regarding how they want to address problems that require intersectoral collaboration. And then, of course, there's the need to address how the health sector engages in intersectoral processes. A lot of research has talked about how the health sector needs to be a driver and a leader in these processes, but really there's other roles that the health sector could consider, such as being a supportive actor, and those can set how the health sector engages with other sectors, which are quite vital, and of course can reduce the predominant biomedical interventions. Thank you.
Fantastic. Thank you very much, Ida. That's a brilliant case study of the first 1,000 days. I'm just checking. So there are no questions for clarification. So without any further ado, I just want to thank you again, Ida. And let's move on to our next presenter, who is Mr. Hossein Buzar Jomehri. He is an Iranian PhD student in health policy with interest in governance, open government, transparency, public participation, conflict of interest, and corruption. So he's currently based at the School of Health Management and Information Sciences in Iran, University of Medical Sciences. And Hussein's presentation will cover factors of the conflict of interest at Iran's health policy making system. Over to you, Hussein.
In the name of God, and greetings to all dear audiences. I am Hossein Buzar Jomehri, a PhD student in health policy in Iran. And today we have a little moment to talk about the factors of conflict of interest in the Iran's health policy system. So we have to start our discussion without wasting time. For many years, we had several health system reforms in Iran, like family physicians, but most of them had been failed. Many studies worked on the cause of this failure and found that officials' conflict of interest as a major cause. The most of these studies we found in this subject had focused on healthcare providers, researchers, and medical products. However, the main problem in Iran is at the health governance level. Therefore, the aim of this study is identifying the factors that cause the COI in Iran's health policymaking system. As a definition for those who are not familiar with this issue, the COI refers to a position when the private interests of an official prevent him or her from performing his public duty properly. For this study, we first reviewed evidences on the Persian and English academic databases, and also general open government data on the internet, which indicated Iranian health officials COI. In addition, we conducted semi-structured interviews with the participation of executive and academic experts of Iran's health system to find the factors of COI. We found 7 main factors. These factors can be categorized into 2 groups, institutional and non-institutional. Institutional COIs means that rather than individual characters, institutional structures put persons into the COI position. In the institutional COIs, conflict of duties is a conflict between 2 legal or moral duties. In this situation, the person cannot perform both tasks properly because the benefits of performing both tasks are conflicting. As an example, members of parliaments in Iran should pay attention to the interests of their constituency, so they may push for unnecessary non-economic services in there. Conflict of incomes and duties means that one's income is in conflict with the goals intended for it. For example, COI in the fee for services payment method is often unavoidable. In the government level, when the health system benefits from providing more treatment, keeping people healthy may be neglected. Self-regulation is another factor that happens when an organization sets or oversees its own rules and regulations. For example, current healthcare providers are responsible for training and licensing of new physicians, so there is a possibility of monopoly and restrictions. For another example, delegating health system regulations such as handling medical errors and complaints and setting medical tariffs to the Medical Council of Iran, which represents physicians, may cause COI. Monitoring of the Ministry of Health over its own service providers is the other example that occurs in the accreditation program in Iran. In the non-institutional COIs, there are 4 factors. Revolving door means having or switching between 2 or more roles, one as a regulator and the other as an executive agent, especially in private sector. For example, most of Iranian health officials are stakeholders, managers, or physicians in public or private healthcare providers or companies. Work or kinship relationships of officials are the other cause of COI, commonly known as indirect COI. For example, a relative of an official has a financial interest related with him. In another example, there is a nepotism, which means that an official employs a relative or purchases goods or services from a relative. Accepting a gift can also influence one's decision. For example, when a pharmaceutical company gives a gift to an official, at last, the officials who have some orientations such as professional, political, ideological, regional, and racial tendencies may lead to policies that serve the public groups, not the serve the specific groups, not the public groups. For example, professional groups may be committed to professional orientations rather than to health system and the public. This study shows that these factors of COI are present in the Iran's health system and they should be considered. Today, there is a ruleless and disordered situation. The findings also show the high probability of regulatory capture in Iran's health system, which means that the powerful actors could capture the government to maximize their own interests rather than the public interest. Therefore, to prevent corruption of other policies, there is a need for COI regulation in Iran's health governance prior to any reformation. Thank you for your attention, and I hope I have made this presentation clear and concise. If there is any question, I will be glad to respond via email. Thank you.
Thank you very much, Hussein. This was a very interesting, thought-provoking, and exciting reflection of on your case study. I think there are one or two colleagues who are joining since we've started this session. Just very briefly, I would like to flag up that please feel free to introduce yourselves in the discussion forum, but also put any questions in the live Q&A section of the platform. At the end of each presentation, we are pausing very briefly for any questions for clarification, and then after all presenters have spoken, then we'll open it up for Q&A. Okay, so thanks once again, Hussein. That was great. I do not see any questions for clarification on your talk. That means everything is perfectly clear. With that, I would like to turn to our next speaker, who is Ms. Nang Trang. Nang Trang works as a researcher at Hanoi University of Public Health in Vietnam, and is also a PhD candidate at Queen's University of Belfast in the UK. Her research focuses in the field of health system, tobacco control, non-communicable diseases, especially breast cancer, and application of economics to health and healthcare. And she has over 8 years of experience in conducting research and managing research projects in Vietnam. Nan will talk about national and transnational actors and their power that influence the tobacco control policies in Vietnam. Nan, over to you.
Good morning, good afternoon, and good evening, depends on where you are in the world. A strange greeting for a strange situation now. But anyway, within the scope of the 6th Global Symposium on Health System Research, I would like to present to you about the national and transnational actors that hold power, influence the tobacco control policy in Vietnam. My name is Gunaran, and I'm working as a researcher at the Hanoi University of Public Health, and I am also a PhD candidate at Queen's University Belfast, the United Kingdom. So in 2012, the first tobacco control law in Vietnam was approved by the National Assembly. By analyzing the key actors and their roles from this approval, we can apply the lesson learned to the current raising tobacco tax proposal in the country. Just briefly about the context of Vietnam, about the tobacco controls activities in Vietnam prior to the law. In Vietnam, 47% of male smoke, which make us to the top 10 countries with the highest daily male smoker in the world. It's not a top 10 that we're proud of at all. But that is also the reason why the government is quite committed to the WHO framework on Convention on Tobacco Controls. We entered the framework in 2004, which is one of the very first countries to enter this framework. And then the framework went into effect in 2005. But as you can see, it still takes around 8 years until 2012 that we can approve the first Vietnamese tobacco control law. So one of the reasons why it takes so long is because one of the key features of the tobacco industry in Vietnam is as the Vietnam National Tobacco Corporation, which holds 55% of the cigarette market shares, is a government-owned tobacco company. So there is conflict of interest here. And now in this slide, as you can see, this is a graph showing the simplified process of how a legislative document is prepared for approval in Vietnam, or in other words, how the system in our country works. First of all, a draft will be prepared by a lead drafting agency or organization, and then it will be sent to concerned agency or organization and the direct objects of the legal documents for reviewing. based on the feedback, the draft will be revised. The circle of revising and getting feedback can be repeated many times. Sometimes it takes years before the final draft can be sent to the National Assembly to be voted for approval. Now, in case of the tobacco control law, the lead drafting agency was the Ministry of Health. The direct object of the law was, of course, the tobacco industry, including the Vietnam National Tobacco Corporation, the British American Tobacco, Philip Morris International, etc. And then we have concerned agency organization, including both national and transnational actors that we will look into more detail in the next slide. And oversees this whole process is the public and the media, our watchdog. In terms of the concerned agencies and organizations, within the government, we have Ministry of Finance, the Ministry of Information and Communication, the committees of National Assembly, including the Committee on Social Affairs, on Laws, and on Judicial Affairs, and the Ministry of Industry and Trade, where the National Tobacco Corporation belongs to, where there is most of conflict of interest. So the actor can review, and they have to review the draft, and then they can request the lead drafting agency, which is Ministry of Health, to revise the draft. They can do it as many times as they want. So the main delay is within these actors. They can just request the MOH to revise and revise the draft. And then we have the semi and non-government organization, which is Vietnam Steering Committee on Smoking and Health, the WHO Vietnam office, the Health Bridge Canada office in Vietnam. These organizations, they cannot request the Ministry of Health to revise the draft. However, they can give feedback, and also they can advocate for the law, for the proposals. Transnational actors within the region and internationally, including SITCA, or the Southeast Asia Tobacco Control Alliance, the Union Against Tuberculosis and Lung Disease, Vital Strategies, and TFK, the Campaigns for Tobacco-Free Kids. They can provide technical support in terms of providing and presenting the scientific evidence to, in the case of the law. And also they provided financial support so that research to gather more evidence can be conducted. Workshops to disseminate the evidence to public and concerned agency organization can be held. And also the the study visits to other countries for the key government officers can be organized. So learn from that experience in 2012, there are some key points, there are 3 key points actually for the current tobacco tax proposal. First of all, the Ministry of Finance is a critical actor. Because of the nature of the tax law, Ministry of Finance is also the one draft the proposals. They are the lead drafting agency. So a strategic partnership between the Ministry of Finance and Ministry of Health is a must to gain support from other actors within the government and to succeed push through the proposals. Evidence from the research is the key to convince concerned organizations and agencies. Vietnamese organizations and agencies or key government officers, they love the research. They love the scientific evidence, so this is a need to present to them. And to disseminate the evidence, the workshops and study visits work great. The key point here is that a policy will never be approved if it only receives support from a sole ministry. Intersectoral partnership among ministries, between the government and non-government agencies, as well as technical and financial support from regional and international agencies are key points and essential to the success. Well, thank you very much for your time and listening. I am happy to answer any question if you may have. Thank you.
Excellent. Thank you very much, Nan. That was a very interesting case study of a truly intersectoral issue with a nice overview of actors who are involved beyond the healthcare boundaries. Brilliant. Okay, so I can see that from the live Q&A that there are no questions for clarification at this point, which means that the presentations so far are all very crystal clear. So it's fantastic. So let me turn to our next speaker now. Our next speaker is Mr. Ryan Gunaran. Ryan Kamada Gunaran is a physician with a PhD in rural development. He also holds postgraduate degrees in community development, development management, training management, and global health. He is the executive director of Doctors for Indigenous Health and Culturally Competent Training, Education, Networking, and Governance, which is a non-government organization involved in indigenous people's health and advocacy in the Philippines. And he is a health policy analysis fellow of the WHO's Alliance for Health Policy and Systems Research. And his topic, the topic of his presentation is managing up, within, and down, how health managers' practices of power influence indigenous health policy implementation for equity and access. Really exciting for this presentation. Over to you, Ryan.
A pleasant day to everyone. I'm Dr. Ryan Gunaran from Benguet State University and Diting from Benguet, Philippines. I'm here to present our study titled Managing Up, Within, and Down, How Health Managers' Practices of Power Influence Indigenous Health Policy Implementation for Equity and Access. So, among the world's most marginalized and vulnerable populations in society are the nearly 400 million indigenous peoples who continue to have poorer health and social indicators than the general population. Recognizing these health inequities, the Philippine government introduced an indigenous health policy which pertained to guidelines on the delivery of basic health services for indigenous cultural communities in 2013. The policy enumerated strategies to improve healthcare in indigenous areas by facilitating access, utilization, equity, and culture sensitivity in basic services. This study aimed to determine how subnational, or what we call regional department of health managers, practiced power and with what consequences for how this policy's implementation materialized. It also investigated the sources of power that they drew on and the reasons for exercising power. This study contributes to the underexplored area of practice of power in policy implementation in low and middle income countries and of indigenous health policy analysis. As a qualitative case study, in-depth interviews with 26 subnational health managers from a case region, of which 22 of them were indigenous, and the review of 15 relevant documents were done. Data from both sources were thematically analyzed following the framework method. In examining the practice of power in implementation, the analysis and interpretation of data utilized a priori themes from two analytical frameworks, namely Veneclasen and Miller's categorization of the expressions of power and Gilson, Schneider, and Orgil's categorization of the sources and reasons for exercising power. Veneclasen and Miller distinguish between power over, which is of a dominating nature, and the more collaborative ways of power with, in finding common ground, power to, enabling potential of person to shape the world, and power within, self-worth and self-knowledge. In understanding the exercise of power, Gilson, Schneider, and Orgil's outline of how micro-practices of power play out in policy implementation, and specifically the concepts of sources of power underpinning its exercise, which is the how question, and the reasons why actors exercise power in such ways, or the triggers for exercising power, guided this analysis. So the results are actors in the case region received the implementation of the new indigenous policy as limited and weakly integrated in health operations. The practices of power, the power over, within, with, and power to of the implementing actors manifested across three administrative interfaces: central, which is managing up, regional, managing within, and the local government units, or managing down. The practices of power led either to action and inaction by them. Although some exercises of power supported implementation, such as the power with other managers in forming alliances to organize indigenous initiatives, and power within and power to act to accommodate indigenous culture in health programs, the dominant experience of the implementation was that the exercise of bureaucratic power over other actors acted to thwart and constrain effective implementation. In addition, the weak supervision of the subnational Indigenous Peoples Health Coordinators was felt to deter policy implementation. The sources of power that underpinned their practices were linked to the regional office context, specifically a top-down norm in the bureaucracy and weak leadership to ensure policy implementation. More commonly, the exercise of or failure to exercise power by the majority of regional program managers constrained implementation, and this was founded on personal factors such as having an attitude of low regard or inferiority for what is indigenous compared to the mainstream or Western health concepts, which implies broader societal factors and issues, and also lack of knowledge and skills on indigenous health and cultural competence. These were generated by a limited understanding of what indigenous health is, being unclear about the need for indigenous people's health in the region, and limited skills for local health interventions. A lack of guidance and incentive was also highlighted as triggering weak support for the policy, as indigenous people's health was seen as an additional task. Defined health activities for indigenous peoples were not also institutionalized in individual performance targets, and the policy was not clear about how to manage instances when indigenous culture may be in conflict with the Central Department of Health standards or other policies. At an organizational level, implementation was inhibited by weak lines of accountability and competing organizational priorities that resulted from the strong top-down management and processes that did not emphasize the indigenous policy integration. Also, the lack of policy and management procedures on cultural negotiation with local government units and the frequent changes in program leadership affected these. Hence, personal and organizational sources and reasons for practice of power were identified in this case with a distinct reference to one's indigenous orientation or indigeneity as a supporting factor. This shows the interplay of the micro-practices of power across the three interfaces, the sources and reasons for these practices of power in the organizational context affecting it. All of these interacted to limit the indigenous policy implementation. In conclusion, the practices of power by actors at key interfaces in the health structure were influential determinants in the implementation and uptake of the indigenous health policy by the health system. The leadership role of a program coordinator and ownership by subnational managers who impact on a broad range of frontline health workers or frontline implementers are crucial in policy execution. Being indigenous themselves, the health managers are most likely to support an indigenous health policy, but personal factors and the organizational and societal context can actually override this tendency. Thank you.
Brilliant. Very much, Ryan. Really insightful experiences and sort of findings, particularly on the interplay between personal, interpersonal, organizational, and systemic kind of groups of influences that can complement or indeed override each other. Excellent. Okay, so let me just quickly check the questions chat. Okay, so our successful run with crystal clear presentations continues. There are no questions for clarification at the moment, which gives us an opportunity to move to our last presenter, last but not least. Mr. Eelco Jacobs is a health governance, policymaking and financing specialist at the Royal Tropical Institute in Amsterdam, the Netherlands. Eelco holds a PhD on the political economy of health systems governance and financing from the University of Basel in Switzerland, and an MSc in political economy and sociology from the School of Oriental and African Studies, SOAS in London in the UK. At KIT, he leads the focus area on health systems in fragile and conflict-affected settings, and is a regular lecturer and tutor in KIT's MPH, Master of Public Health program. Eelco has previously worked in various roles in health governance, corruption, and policymaking for various organizations, including the WHO, European Commission, the NGO, CORD, AID, and the Basel Institute on Governance. And Eelco's presentation title is Synergies in the Movements Towards Universal Health Coverage in SRHR. And he will explain what that means in the presentation. Lessons from Ghana, Thailand, and Mexico. Eelco, over to you.
Hello, everyone, and greetings from the Royal Tropical Institute here in Amsterdam. I'd like to present a study to you on how SRHR has been advanced through universal health coverage reforms and lessons. We took lessons from case studies in Ghana, Thailand, and Mexico. This was a study that was initially funded by the German GIZ, Cooperation for Development, International Development. I'd like to recognize also the contribution of my colleagues here to this study, as written here. So our objective was to understand how universal health coverage reforms have been used to advance sexual and reproductive health and rights. And we looked at 3 countries that are often seen as frontrunners for UHC on their respective continents: Mexico, Ghana, and Thailand. We paid particular attention to the role of civil society organizations in the expansion of SRHR through universal health coverage reforms. And we identified a couple of opportunities or areas that seem, interventions that seem successful for advancing the agendas. We used literature review, key informant interviews at policy level in the 3 countries as methods of data collection. And we validated the findings at 3 roundtable meetings with, particularly with stakeholders from the field of SRHR. Now, I think many know UHC and SRHR are core elements of the SDGs, and both are grounded in common principles of human rights, equity, dignity, and non-discrimination. We mainly used the definition of a UHC as aimed at increasing population coverage for health services, affordability of care, and a range of services in health benefits packages. For SRHR, we used the new comprehensive definition of SRHR as formulated by the Gunaran definition, which places also more emphasis on sexual health, sexual rights, and reproductive rights, in addition to just reproductive health. So in the 3 countries, we observed that UHC reforms through health benefits package design, which we mainly looked at, have led to a real expansion of SRH services. But not all services of the comprehensive SRHR agenda are included in all countries. Particularly safe abortion care and infertility services are not included. In Ghana, sexual and gender-based violence, trauma care, and counseling for modern contraceptives for adolescents are not included. and also around ARVs and treatment for certain STIs is only partial coverage. Now, what facilitated this expansion? In Mexico and Thailand, civil society was really instrumental in expanding SRH coverage. In Mexico, the lack of progress against MDG 5 was really an impetus for reform, creating political momentum to do something about it. And the Center for Reproductive Health and Gender Equity, sort of an umbrella for various civil society organizations in that field, was really active in pushing for the inclusion of more SRHR services, and particularly the inclusion of the emergency contraceptive bill is a nice example of their success. Only happened after intense advocacy from them. In Thailand, HIV advocacy groups were particularly well organized and active in the process of benefits package design. And the Health Intervention and Technology Assessment Program was also set up to include stakeholders in that process of priority setting. And this led to the inclusion of ARV therapy and also later even pre-exposure prophylaxis in benefits packages. In Ghana, civil society engagement was less effective, although they were formally included in a few consultative meetings. They were less effective in the inclusion of SRHR services in the basic package of the National Health Insurance Scheme, which led to less emphasis on sexual health and rights particularly. And that also shows some of the barriers. A restrictive legal environment, particularly around abortion and the rights of LGBTQI community, was a barrier to the expansion of SRHR services in benefits packages and more broadly. Also, limited space for citizen and CSO involvement or limited institutionalized involvement was a factor, and of course resource constraints. And it's just noteworthy that rights-based approaches usually do not feature in health benefit package design processes, which are often taken as purely health economics exercise. And of course, despite the inclusion of SRHR services in health benefits packages, many access barriers remain in practice. And geographical access, shortages of human resources for health, stigma and taboos. But although these came up in our interviews and literature, was not the main focus of our study. Now, we can conclude that CSOs can really be effective if they have a clear political agenda and use political momentum and opportunities. The case of Mexico and Thailand really show that. And health technology assessment guidelines are also a promising tool for this, as shown in Thailand. These stipulate that civil society organizations are included in the formal process for priority setting. But more is of course needed, particularly around strengthening the legal framework around, for example, abortion rights, the rights of the LGBTI community, and youth. There's a lot to win there. Also, the enhancement of citizen participation is really needed. And can be an opportunity for advancing SRHR. And multi-sectoral action, of course, is needed to more broadly advance SRHR. Only benefits package design is not enough. Talking about youth-friendly health services, institutionalizing and strengthening the legal framework around prevention of SGBV, comprehensive sexuality education, and reach out through social media as a mobile phone app in Thailand shows. This was successful in reaching youth in SRHR. around the theme of SRHR. Thank you for your attention. If you have any questions, you can reach me at my email address written here or visit us on our website. Thank you.
Fantastic. Thank you very much, Elko. Can I, at this point, ask all panelists to unmute your microphones and put your cameras on? So that was a great combination of presentations covering some health specific issues such as the first 1,000 days and kind of sexual reproductive health from Ida and Elko respectively, and as well as broader policy kind of environment and conflict of interest from Hussein, as well as kind of truly intersectoral issues such as tobacco control from Nan and engagement with indigenous populations from Ryan. So this is an opportunity for us to have a bit of a discussion and also questions. So thank you very much. I can see questions are coming through. I think the first question is actually addressed to all colleagues. So what are the key lessons of your work for others seeking to support health policy change? Being clear to which actors your lessons are addressed. And that is a question from Lucy Gilson. Maybe if we could start with this quick round, perhaps going through individual presenters, and then we'll see if we will accumulate any further questions. I will go in order of the thumbnails on my screen. So Ryan, apologies for putting you on the spot. Are you happy to go first? Maybe kind of reflecting on Lucy's question in a minute or two.
Thanks, Tolib, and thanks, Lucy also. I think in my case study, it was really particular on one, indigenous people's health and how triggers and reasons for practicing power were conflicting with the administrative structure of the local health system and how this played out to actually deter the implementation of the indigenous health policy. At the same time, I looked into middle managers' role. Sometimes we miss out on the middle manager's role. We just look at the central and the frontline or the street level bureaucrats. But the middle managers really hold a lot of power in terms of interpreting policies also, because they affect a lot of other implementers down the line. I think that's the key message. Thank you.
Excellent. That's very crisp and clear. Ida, can I turn briefly to you? Who are the main kind of target stakeholders for your messages? Please go ahead.
Thank you. I think for me, it's two groups of actors. I would say the first one is for those who are advocating for intersectoral collaboration, so policy advocates who have come out in some of our studies, civil society organizations, those who are involved in that level of agenda setting and prioritization of policies, to just have a sort of clear mind of how prioritization happens, and that agenda setting is really not the end of the policy, that there's a whole level of middle management and implementation that comes into play. And for considering how to advocate and lobby in such a way that you try and think of some of the barriers that the policy will experience as it goes through those different levels and those different actors. So who do you involve during agenda setting, for example, whether that has an impact later on during implementation, who gets left out, who actually owns the agenda, and how that plays out during moments of decision making, during formulation. So that would be my one group of stakeholders. The second, of course, would be those involved at policy formulation level for my case, because that was really where, the policy experienced a lot of setbacks. So how do formulation activities happen, and who gets involved in that stage? How do you try and think about creating a common or a shared understanding of an issue? So I would categorize those two actors as important in my case.
Fantastic. Thank you very much, Ida. That was good. Elko, can I turn to you briefly? So who are the main target beneficiaries of your policy recommendations?
Yes, hi, thank you, Tolib, and thank you for this interesting question. So, yeah, it must be said, first of all, we were asked by GIZ to do this work. And we've also been asked by SIDA, a Swedish International Development Agency, to to reflect on the synergy between the movements and the paradigms around SRHR and UHC. So yeah, to be honest, that was the first target audience for what we did. But then more broadly, I think what we did. There's some lessons there for policy advocates in both the areas of SRHR and UHC. Interestingly, I think what we noticed and also what we just realized when working on this with colleagues coming from both SRHR field and from the health systems UHC field is that so much work on these topics is done in silos, and also policy advocates in the field of SRHR tend to be very focused on those in power dealing exclusively with SRHR is sort of what we found out. And well, that there's sometimes a missed opportunity there. So better aligning to other developments in health system strengthening, and also in particularly in areas like health financing, advancements in health financing towards broadening universal health coverage, is really an opportunity for SRHR advocates to also get more access ultimately to SRHR services. So I think that's an interesting lesson that came out of our work. There's much more to say, but thank you for your interest.
Brilliant. Thank you, Elko. Hussein, can I quickly turn to you? So who are the main target stakeholders for the policy recommendations from your study? Over to you. Make sure you unmute yourself.
Thank you. Yes. Thank you. I want to thank you and all the colleagues who are here. I think the main findings of this study was that we have many factors of conflict of interest in Iran, and maybe some other countries that have the same situations. And if we want to make policies and reforms in a situation that policymakers have a conflict of interest, major conflict of interest, the policies may be corrupted. So the managing of conflict of interest at the higher level of policymaking system is a priority. And without doing this, we might have a government capture, governance capture, or something like that. And I think there is not a health policy issue alone. It's a public administration issue at a higher level, and we should consider this conflict of interest about the policymakers beyond the health system and the upper authorities should consider this and manage this before any other policy making and reformation, as I said, like the family physician and referral system we had, and these reformations have been corrupted because of conflict of interests.
Fantastic. Thank you, Hussein. Can I maybe briefly turn to you, Nan? Still on the same question from Lucy on who are the target stakeholders for the policy recommendations. I think they were pretty kind of evident from your stakeholder mapping, but if you want to maybe kind of reflect on that briefly, over to you.
Yes, so thank you for the question. In the case of the draft proposal for raising the tobacco tax in Vietnam, Ministry of Health is not the key actor. Of course, we want to push through to raise the tax to have with tobacco control activities, but the key actor here actually is the Ministry of Finance, because they are the one who will draft the proposal and approve that first draft. If we can move them, if they won't move the proposals, it will be already failed from the start. So they are the key actors. And another key actor after the Ministry of Finance will be the Ministry of Industry and Trade, because they are the owner of the Vietnam National Tobacco Corporation, which is hold 55% of the market share in tobacco in Vietnam. So they actually it's like a double actor there. Because of that conflict of interest, if they approve, we also have like half of the approve from the industry. So that will be a big push for the proposal for the law. So that is a key, two key actors in our case.
Excellent. Thank you very much. Okay, so we've got a few more questions coming in. I think one of them is specifically addressed to okay, sorry, there is a follow-up on Nan Trang. So what are the key lessons for health policy actors about how to influence people working with the Ministry of Finance? So do you want to briefly reflect on this, Nan? And then we'll move on to further questions.
Yes, thanks again for the follow-up question. So from my experience, yes, with working with Ministry of Finance is really tough. They are hard to move, but one of the few key actually, and the key things when we want to move them is that we have to show how the benefits come from the tax. And if we raise the tax, actually, we need to show them the benefits that come into their budget. It is raise the budget and the revenue that come to the Ministry of Finance. And we also need to prove that even all of the policy that do maybe benefits for the Ministry of Health in terms of health people, but it actually also have within the Ministry of Finance. So they need to see some benefit there that they are willing to fight against the industry. If the policy is something like can reduce the revenues and also didn't bring them any benefit, I don't think that they will really agree with the policy change. So that is the approach that actually the activities within the country try to approach when we work with the Ministry of Finance.
Excellent, thank you. The question that was addressed, I think one of the questions was specifically for Ryan from Mary Ruth Politico. And the question is, do you have recommendations on how to address weak lines of accountability across levels of governance? So can I briefly turn to you, Ryan, if you want to reflect on ways of addressing the weak lines of accountability?
Okay, thank you very much. Thank you, Marianne. I think one finding here was very, very strongly the incentive mechanism and the monitoring and evaluation systems really have to be very firm. The targets that are being given to the program managers was, I think, the major factor in trying to implement a policy. So when a policy comes out, while it's being formulated and designed, it really has to have a strong M&E structure with it, and you could put in there some incentives and motivation mechanisms to really make it through. Practically, that has been the major factor that I think that I saw in my case study. And of course, the policy should be clear. It has to be harmonized together with other policies that are being implemented, because we're competing with many other policies. And third, you have to have a strong policy leadership. You have to have a strong champion within the institution, such that the reforms will be institutional in nature. So I think that's my reflection of that. Thank you.
Okay, brilliant. Thank you. Our next question is from Helen Schneider. So she is thanking everybody for the very interesting presentation and also posing the question, to what extent do the relations of power and key actors depend on the policy issue under consideration? Maybe if I could turn to Ilko. There was a very interesting policy issue in relation to sexual and reproductive health and rights. And perhaps if I could then turn to Ida, if you start preparing yourself so that to reflect on the same question. Perhaps Elko first, over to you.
Right, now it absolutely depends on the topic at stake. Obviously that the topic dictates what stakeholders are involved, really, what stakeholders are interested, what stakeholders have a strong interest, a strong stake in the matter. What was interesting to me is that in the different cases, you saw that the political setup and the way ministries and other policy stakeholders set up the process also gave space or limited space for, in this case, civil society organizations to be involved. So in Thailand, despite the fact that there is in a way a restrictive political environment with the role of the military there, the process was set up really following guidelines for priority setting with inclusion of civil society. So the Health Information Technology Assessment Program that really, that just by law, I believe, gives space for civil society actors to be involved and to have their say. And that also really led to a rather progressive SRHR agenda. And similarly in Mexico, the process was set up to be inclusive towards citizen groups and civil society organizations. And in Ghana, you saw that the process for determining and revising benefit packages was done in a much more sort of informal ad hoc manner, giving less space to civil society and citizen involvement, really. So the institutional setup also really matters here. And it's not just a reflection of the regime generally, as the Thailand case shows. I think that was quite interesting to me. There's a lot more to say about it.
Fantastic. Brilliant. Thank you very much, Elko. Ida, are you happy to reflect on the same question? Please go ahead.
Yes, thank you. Thanks, Helen, for that question. While I agree with what Elko has said, that of course the policy issue itself might determine who the key actors would be, I would also think that in government institutions that work in a certain way, then across a number of policy issues, there will be a couple of actors who would be the same in a number of policy issues. And maybe that's the challenge really in trying to develop policies that policymakers are juggling a whole set of different policies that they have to address at the same time. And some key actors would affect how the policy, how a different number of policies turn out. So Ministry of Finance, of course, is at the center of a whole couple of interventions. And so I do agree that the policy issue can, of course, influence, the controversy and which actors would be involved. But, government systems are set up to have the same actors deal with a couple of policy issues. And so those actors would feature in a lot of policy issues. And so the forms of power that they employ would also be the same in a number of policy issues. Thanks.
Brilliant. That's excellent. And thank you everybody for being very concise and clear. Perhaps if I could also sneak in one of my questions, maybe to Hossein. You have talked about institutional and some of the non-institutional factors that affect these conflict of interest in policymaking. I was interested to dig a little bit deeper and understand what are the key, maybe one or two top individual factors that you may have come across in your research. Has anything come across in relation to kind of people's values or interests or any individual factors? Over to you.
Thank you. I don't know what's the exact point of you mean that individual factors. I think, in my opinion, some individual factors, maybe the professional factors. In example, I said that in family physician implementation in Iran, the specialists who were not agree with this policy confronted with this policy. So the professional factors, I think, is a major individual factor, at least in Iran. But the relationship with industry and some private organizations like private hospitals or other companies is another individual factor. I think it's very important in Iran, and I don't know if is there any question or other meaning you have you wanted from the individual factor. I don't know if my answer was correct or you mean something else.
No, thank you very much. I don't think there are correct or incorrect answers, but that is very helpful. Thank you. Brilliant. I think we're pretty much towards the end of this session. We have had a series, well, 5 really interesting and in many ways complementary presentations covering this topic of power across the different sectors and from the different angles. So Ida started with covering the case study of first 1,000 days in South Africa. Then Hossein reflected on the conflict of interest in policymaking in Iran. Then Nan reflected on the tobacco control policy in Vietnam. Ryan reflected on indigenous policymaking in the Philippines, and Yelko has shared the really interesting cross-country comparison between the different countries in relation to sexual reproductive health and rights. So we had a good discussion, wonderful questions from the audience, and brilliant engagement from the panelists. So can I thank each and every one of you and for engagement. It's been a brilliant session. I'm really kind of happy to be part of it. Perhaps a reminder for colleagues to engage with panelists through the symposium platform, but also through the emails. I'm sure our panelists will be very happy to answer further questions and engage further. On that kind of a very positive note, I wanted to kind of, I don't know if it is feasible to do the virtual class, but I certainly will do the physical class for each and every one of you. So well done, everybody. Congratulations on a successful session, and we'll see you in the virtual space. Thank you and goodbye for now.